Okay, hello everybody, this is Dr. Pruett. Keeping with the respiratory theme, let's imagine that you're dispatched to a 6 Delta and you're thinking on your way of all the things you want to be prepared for and what you might encounter when you get there. When I'm thinking about a patient with a shortness of breath issue, I have 5 big categories that I put them into. The first one is this could be a problem with their head. Are they having some sort of intracranial hemorrhage? Is it a stroke? Is there some trauma? We all know that the head drives our respiratory center, and that can lead to breathing difficulty. Another issue would be the heart. Could this be an MI or some sort of fluid overload with congestive heart failure, or probably a valvular problem, or anything that might be wrong with the heart can also lead to problems with breathing. Today, obviously, in our respiratory series, we're going to focus on the lungs. So this will be where we spend most of our time today, but obviously lungs can cause shortness of breath as well. And then blood. Number 4 would be, mostly when I think about this related to shortness of breath, I'd consider anemia a probable cause, because it is the red blood cells that are delivering oxygen to the tissues. And if there's some problem with that process, it can lead to shortness of breath. And lastly, could this be a musculoskeletal problem? Is there some sort of diaphragmatic issue or maybe paralysis issue or something else going on with the mechanics of breathing to where this patient is having difficulty? So those are my 5 big categories that I bunch these patients into, and then I narrow it down as I go. If you look at COPD across the country, obviously there's some places in the southeast where smoking is more prevalent than other areas of the country. But if you look at New Mexico, our rates of COPD are actually pretty high, comparatively speaking. Now, the reason this is important, and I know you all know this because you run on these patients all the time, but COPD is actually the 4th leading cause of death in the United States. And in some areas, and some of the literature I read, it's actually the 3rd leading cause of death. And it's the 2nd leading cause of disability. So this is a very prevalent disease, and it's a very deadly disease. Now, what exactly is it? The definition, the key word here is chronic obstructive lung disease, and we'll get into some pictures and hopefully some deeper understanding of why it's called an obstructive process. But basically, it's a progressive and irreversible disease that's caused by inflammation that makes it difficult for air to flow in and out of the lungs and to do the oxygen exchange with the red blood cells. This can be broken down into 2 types. One type is emphysema, and this is where airways are actually physically undergoing destruction. And the next is chronic bronchitis, and these are the patients that have excessive mucus and a predominant cough. Both of them are obstructive processes, and there can be mixes of the 2 types, but most patients have predominantly one or the other. To start off with, we need to always like to understand normal before we start talking about abnormal. So when we look at a normal lung, you see the blood coming from the heart, the deoxygenated blood coming from the right side of the heart, is closely tied to the airways. And they go down into the really distal tiny parts of the airway where the gas exchange occurs. So the blood that needs oxygen is taken to the lung, where ideally it picks up oxygen and goes back to the rest of the body. Now, the key to making this happen is the alveoli. And what makes them useful is if you look at this microscopic slide of the alveoli, what you see here is a whole lot of white space with basically 1 cell layer thick of a membrane. And in that membrane is a place where red blood cells can pick up their oxygen and exchange their carbon dioxide. The key to this being successful is that there's lots of room and it's not much congestion so that the gas exchange can occur. Now, if you were to look at the lung under an electron microscope, like you see here in the bottom right, the lung actually kind of looks like a sponge, right? Lots of room, lots of air, lots of room for the body to do its job. And here's even a closer look at the alveolus. This is the main component of the lung where the gas exchange occurs. And again, if you look at this circle in the middle, tons of room for air to come in and out. And it's surrounded by red blood cells where they can drop off the carbon dioxide coming from the body that's been doing its metabolism and pick up oxygen. And there's some other scattered cells around there too. Those are white blood cells. They're looking for invaders. There's not a lot of them, but they're there to help. And usually around that alveolus, if you look, it's just about enough room for 1 cell layer around it. and then lots of room for air and a lot of surface to area ratio for the gas exchange to occur. Now, what happens with COPD patients? If you start at the top of this diagram and you look at the cigarette smoke, because cigarette smoking is one of the predominant causes of this disease. It's not the only one. There are some genetic diseases that cause it too, but usually it's tied to smoking. But for whatever reason, in our COPD patients, they're exposed to chronic toxins. So for this example, we'll use smoke. Now, this chronic exposure over time to a lot of toxins in the lungs causes an immune system activation. And if this happens just one time, it's usually not bad. That's the body doing its job. But if the body is constantly exposed to this toxin over years and years, the activation of that immune system is going to be constant. And if you look at the cells that are coming in, you have fibroblasts, neutrophils, monocytes. Those are all white blood cells that come in and try to fix the problem. And over time, the way that they fix this problem is by causing fibrosis or destruction or mucus hypersecretion. This is the body trying to do its job to wall off these invaders. And it causes essentially remodeling of the way that the lung works. So again, if we start with normal lungs, you've got the air coming in through the bronchus and the bronchioles, goes all the way down to the alveoli where the gas exchange is going to occur. That's the way that it normally works. Lots of blood flow, lots of air coming in and out, not much impedance. But if you look at a lung that's got emphysema, there's some changes we want to highlight here. So if you look up at the very top, if you start in the big airways, what you see, again, to that chronic toxin exposure is going to be a lot of edema and a lot of mucus. And then the diameter of that airway gets a lot smaller. And then if you move down to the smaller airways, what you see here is a lot of fibrosis and narrowing of the airways. That airway gets scarred down. As there's more and more inflammation and more trauma to that airway, it's going to scar and not be as elastic. And then as you get farther down into the more distal airways, what happens with that chronic inflammation is that the airway actually kind of gets eaten away, and there's not as much opportunity for gas exchange because that one cell layer thick of alveoli kind of gets eaten away and it can't do its job. So again, if we start with normal, here's a normal lung under the microscope. Slide A is a fairly sizable chunk of lung, but you see a fair amount of white in there with some cell layers, normal looking lung. And B is just a little bit closer up. Again, nice, you see some bigger airways here that are more conducting airways, and then some of your smaller alveoli out towards the edges with that, again, that one cell layer thick of lots of room, lots of opportunity for gas exchange to occur. If you compare that to an emphysematous lung, what you see is what we just talked about. So a lot of destruction and a lot of stiffness is happening with those changes over time. So this airway on top here, slide number C, not nearly as many cell wall layers or opportunities for red blood cells to get into those alveoli and do their gas exchange. And if you look at it even closer, you can see the little stubs here in these alveoli where there's just no continuity for blood flow to come in and gas to go out. So if you look at emphysematous lungs under macroscopic inspection, you can see here on the left that as those fibrotic changes are happening and the airways are being eaten away, it forms what looks like bubbles on the outside of the lung. And those are actually called bullae. And you can look at the picture on the right, and they're obvious to the naked eye. They can be very big and very pronounced over time. Now, the thing about these bullous changes is that if they are just like a bubble, they're prone to pop. And so your COPD patients, if they have too much intrathoracic pressure, these bubbles can pop and cause a pneumothorax. So it's easy to see how that can happen when you look at the physical manifestations of this disease. Now, the second type of COPD, chronic bronchitis, has a little bit of the same, but it's also a little bit different. So if you look at the normal lung on the left, there's a nice big airway with one central area where the gas exchange can occur and the blood cells live. And then there's all these nice alveolar membranes that are intact and have lots of room to do the air exchange. But if you look at the chronic bronchitis lung on the right, you see that the main airway is very congested. It's full of mucus, it's full of extra cells, it's full of inflammation. that narrows the airway, so there's not as much air getting in, and that also increases the pressure in the airways. And if you look out on the periphery from the main airway, what you see is more destruction of the alveolar membranes and less room. Just like in emphysema, there's less room for the gas exchange to occur. The thing with chronic bronchitis, though, is that the predominant symptom is going to be this mucus production and the inflammation in the bigger airways, whereas emphysema is mostly destruction in the smaller airways. Now here's another just diagram to kind of drive the point home. If you look at the normal lung on the left, we'll say this is air coming in, and the nice big blue bubble on the left, that's where air goes in, gas exchange occurs, and air goes out. Some airways can have mucus, not that big of a deal. That's why we cough. That's our body doing its job. But if you look at the airway on the right, this is a COPD airway, and this is why we call it obstructive. What happens with these changes over time is if you look at what the airway is doing as the patient tries to exhale, the airway actually collapses around, and then there's a mucus plug that's making it really hard for air to get back out. So air gets trapped in the alveolus, and even though it's in there, there's not a lot of red blood cells getting to the area to do the gas exchange. So you're retaining CO2, and they're having a really hard time exhaling. And a lot of that is due to the loss of elasticity or the scarring that happens with the chronic inflammation. And then air gets trapped, it can't get out, and their chest and their airways get hyperinflated. And now it probably starts to make sense why in COPD, the CO2 levels of these patients are going to be high, because all of that air is stuck in their lungs. And it also starts to make sense why their expiratory phase is going to be prolonged, is because they're trying to squeeze that air out of their lungs. What normally happens for the rest of us is that air just kind of rebounds out of the lungs without a problem. But in COPD patients, they're having to squeeze their chest, purse their lips, create some intrathoracic pressure to actually push that air out of that congested airway. And asthma is actually a very similar process to COPD. It's inflammation in the airway, so you have a narrow diameter of the airway, congested cells, difficult to do gas exchange at the cellular level. They're both obstructive processes, and that's why our treatments are very similar for both processes. And if you look at an asthmatic lung under the microscope, you can see here again, nice big open airway, lots of room for gas exchange. And you look at an asthmatic lung in comparison, tons of extra cells, tons of congestion, not much room for air exchange. It all starts to make sense what's going on and why they're having trouble breathing. Again, here's just another look at COPD versus asthma. So even though they're both obstructive processes, there is some subtle differences at the cellular level in terms of what's going on. So if you look at the COPD airway on the left, it is just like asthma going to have some mucus hypersecretion, but they're not going to have the intact alveolar membranes because of that cellular destruction. And the gas exchange will be a little bit different. Whereas in asthma, usually the alveoli are fine. The problem is in the swollen airways and the mucus production in the bigger airways. Either way, they're both obstructive, but there's some subtle differences at the cellular level. So now that we understand what's going on inside the lung, our capnography is going to start to make sense. So again, we'll start with normal. Normal capnography readings are going to be 35 to 45. You can see a nice square waveform here, and it starts to make sense. Your inspiration time is this nice blue square here as the patient takes a breath in, they reach their max end tidal, and then the expiration phase will be here. Nice square waveform, that's what we're looking for with a normal respiratory phase. But when you start to consider our COPD lung and the air that's getting trapped in there, this starts to make sense. It becomes a shark fin. So we know that there's lots of carbon dioxide that's trapped in this area, so our end tidal, that peak right there, is going to be higher. So we're looking at 60, sometimes 80. I've seen patients even with 100 that all that carbon dioxide can't get out because no air exchange is happening. So they're going to have higher end tidal readings. They're going to have longer expiratory phases, like we talked about. They're going to push that air out and create some pressure. So it's going to create that shark fin kind of waveform. It starts shark fin, it starts kind of low because the body's naturally going to try to do that expiration just as a rebound with the chest wall. But then the patient realizes that's not going to be enough, so they slowly start to push and push and push. And then as they push and prolong that expiratory phase, they're getting more and more CO2 out. So eventually it starts to peak. But that expiratory phase is going to be prolonged. Now, what happens with COPD exacerbations? Because people live with this all the time, but these lungs are so sick kind of at baseline, it's really easy for them to fall off the cliff. So any kind of infection or dust in the air or changes in altitude, normal lungs have a lot of capacity to absorb insults. That's the way that they were designed. But these lungs kind of at baseline are functioning on their last leg, and so any little insult is going to make it more difficult for that patient to breathe. Now, it's important for us to realize in the medical field, I know we run on these patients all the time, but when they have reached the point where they're calling 911 for shortness of breath and need our interventions, a third of these patients are going to die within 1 year the first time that they call. So these are very sick patients, and we need to respect what's going on in the lungs and how sick they are. Now, things to think about when you go to this patient with COPD, they're going to be at higher risk just baseline because their lungs aren't functioning the way that they're supposed to. They're going to be at high risk for infections. So pneumonia or upper respiratory tract infections account for up to like 75% of these patients' hospitalizations. Usually it's infection. But like we talked about, sometimes they can have a pneumothorax. If one of those bullae or blebs pop, that can cause a pneumothorax and increase their respiratory distress. They are at higher risk for PEs. Because their lungs are so sick, it puts stress on their heart, so they're usually at risk for cardiac ischemia as well. And then obviously they're higher risk for cancer too. So these are pretty high risk patients. And a little bit of physiology here. Hopefully it's not too much, but I just think it's so cool how the body adjusts to a lack of oxygen here. But there's something called ventilation perfusion mismatch, and you might hear it referred to as VQ mismatch. And essentially what that means is that the volume of blood exceeds the volume of oxygen down in those small airways in the capillaries. And that leads to a respiratory acidosis. And I know that's a lot of big doctor words, but really what happens here is that what's happening is these lungs, it starts here with this retention of CO2, which we just explained. There's a buildup of the carbon dioxide that can't get out because those airways are so congested and the airways are so destructed that the blood can't get in. And so there's not enough oxygen coming into the lungs, and there's an increase of CO2. And the body and the brain has the ability to detect areas in the lung where this is happening, and it basically shuts them off. I think it's fascinating how that works. But if the brain detects an area of the lung that doesn't have enough oxygen, it clamps down those vessels and makes them smaller. If you look at these capillaries around here, and it essentially shunts blood to the areas of the lung where the blood flow and the gas exchange is happening like it should. So it's pretty fascinating how our lungs recognize that and send the blood to where it needs to go to be maximally effective. But on the backside, what happens with that is that it's increasing pressure in these lungs. And so as there's more vasoconstriction with more hypoxia, what happens when you close down like on a straw? You have to increase pressure, right? So the pressure in those lungs gets higher and higher. And as there's more and more destruction in those lungs, the pulmonary pressure gets higher and higher. And that backs up and causes pressure in the heart. And over time, we know that the right side of the heart is intimately tied to the lungs. So usually what's going on in the lungs will eventually affect the right side of the heart. And as those pressures increase and there's more and more vasoconstriction from the lack of oxygen in those lungs, it's going to increase pressure in the pulmonary artery, and it's eventually going to increase pressure in the right heart. And that's something called cor pulmonale. And the way that we can see this is we can see it on X-ray, but we can also see it on EKGs. So as the lungs start to work around, the body tries to fix itself all the time. So as the lungs are trying to increase their capacity to get more air and increase their ability to do the oxygen and carbon dioxide exchange, they're going to become hyper expanded and kind of full. But what that does is as these lungs get stiff and non-compliant and they're trying to get more air in, it's going to actually physically compress the heart and rotate it towards the right. And why that matters for you is that you're going to see signs of right heart strain on the EKG. So you might see right ventricular hypertrophy, you can see right axis deviation. That heart has physically rotated in the chest based on the pressures and is going to change the vectors on your EKG. You might also see a right bundle branch block. Sometimes it can cause atrial fibrillation. Sometimes it can cause weird-looking P waves and multifocal atrial tachycardia. Now, if you look at this heart over here on the right, usually the left side of the heart is twice as big as the right. But this right heart has had such high pressures and has been so congested for so long that it's actually remodeled. And if you look at this right atrium here, it's huge. There's no way it should ever be that big. And it's stretched out, and it's all because of the pressures going into the lungs. That right heart has had to compensate, and you can tell that the right heart has remodeled as a consequence. And if you remember, the sinoatrial node is located like right down here in the right heart. So as this atrium starts to stretch and as this right ventricle starts to stretch, it starts to make sense how physically you can start to see atrial fibrillation, or you can start to see bundle branch blocks, because those branches are literally getting stretched and pulled and sometimes broken by the remodeling that's happening. So when we put this all together with a patient, it makes sense what you see. So you're going to see them sitting in a tripod position that opens their airway so they can get more air in. They've developed a barrel chest over time, again, to try to compensate and use those the muscles in the ribs and the chest to start help with their breathing. There's going to be some clubbing in their fingers. They're going to be pursing their lips because they're basically giving themselves some auto PEEP. That's increasing their intrathoracic pressure. They're going to have that prolonged expiratory phase. They're trying to force out that CO2. And then you're going to see the retractions and the accessory muscle use as they're working hard to breathe. So the mainstay of treatment in COPD is going to be supplemental oxygen, because as they're working harder, whatever has tipped them over the edge, whether it's infection or pneumothorax or whatever, as they start to work hard, they start to use those accessory muscles, that's going to increase their oxygen consumption. So it starts this kind of circle that they just can't get out of. They're going to work harder, they're going to consume more oxygen, but then they need more oxygen. So the first thing we do is give them more oxygen. Basically, their ventilation and perfusion mismatch has taken over and they just can't get enough oxygen. So as their hypoxia gets worse, those blood vessels are going to get more and more constricted, and that's going to increase the pressures. But as they do get more oxygen and we start to get more oxygen to those areas of the lungs that needed it, those blood vessels are going to start to dilate. And initially, you might start to see worsening of their hypoxia as the body is trying to adjust and dilate those blood vessels in the lungs. One important history question to ask is how much oxygen they have at home as a baseline requirement, and if that has gone up lately. One of my favorite treatments for COPD is our CPAP machine. It starts to make sense why positive pressure is so important in these patients. When you understand what's going on in their lungs and there's so much congestion and so much tightness in that airway with mucus and inflammation, the positive pressure basically just helps stint open the airway so you can force more oxygen into the airways where it needs to go. And the indications for this, in my mind, are the patient basically who looks like they're in respiratory distress. If they're tripoding, if they're having increased work of breathing, if they look like they can't breathe, and you're getting high end-tidal readings on your capnometry, that's the patient that needs this. And it makes sense when you look at that airway again. They're trapping that CO2 in there, and we need to help them get that out. So by putting positive pressure in this airway and preventing that bronchial wall collapse and helping that air get around the mucus and the inflammation, just with a little bit of extra pressure, it's going to help them breathe better. This is really the gold standard for treatment of COPD. It helps increase their oxygenation. It decreases their work of breathing. Over the years, it's really decreased the need for intubation in these patients, which to the chagrin of many residents in the hospital because they're not getting as many intubations as they used to. But it's really better for patients. It shortens the hospital stay, and overall, it's been proven to improve mortality. And I think the coolest thing about it in this state is that it's an EMT basic skill. So anyone can do it. Anyone can recognize this patient and give them the life-saving treatment that they need. Now, there's obviously some adjuncts to treatment that we have in the department. Ipratropium and albuterol, or a Duoneb is a go-to, as well as dexamethasone and magnesium. Now, the way that these work, if we start with the Duoneb, it basically helps dilate airways. Again, we're attacking this airway from every possible angle to help it open up and do its job. So the albuterol is going to be the beta-2 agonist. That's the fight or flight thing that works in coordination with epinephrine. And essentially what it does is it lowers the calcium inside the cell and helps relax the smooth muscle so those airways will open up a little bit more. Ipratropium acts a little bit differently. It's an anticholinergic medication, but again, essentially the same thing. It dilates the bronchial smooth muscles so that we can get more air where it needs to go. And it also has the added benefit of decreasing the mucus production that's going on in those bigger airways. I love magnesium. The way that it works is pretty complicated, but I do think that it's a great adjunct to help in these patients. It essentially just helps with vasodilation and smooth muscle relaxation. I know it does take some time to set up and does need to be given IV, but I'd keep it in your back pocket for your patients that are in severe respiratory distress. And then there's dexamethasone. So this is a really potent steroid that has good anti-inflammatory effects. I like it in the pre-hospital setting because it acts relatively quickly. Anywhere from 10 to 30 minutes is at onset, and it can last a patient for up to 3 days. And one of the coolest things about it is you don't need to take your time getting an IV. You can actually give the same dose you would give through the IV, just give it orally. And this is a fantastic option in kids as well. If you look at how steroids work, basically what it does is decrease the inflammatory cascade and decrease some of the tissue reactive factors to, at the end of the day, just decrease inflammation in those airways. Now, epinephrine, everybody talks about epinephrine. I kind of think of it as my nuclear option. Everyone knows our doses, but I try to reserve it for the patients, the COPD patients who I feel are really, truly about to go into respiratory arrest, because it does have so many adverse effects on the heart. I try to save this as my last resort and give the patient 5 or 10 minutes on CPAP with all the other medications. And if they're just not getting better, then don't be afraid to use it, but just be cautious. The benefit that it gives you is that it does relax those bronchi, but it has, as you see here on this list, in the sympathetic system, it's got a whole other host of interactions as well. So when I think about it, I just kind of weigh the pros and cons with your patient. It's very potent, and it'll probably do the job and help open those airways. But you just need to be aware that it can worsen any sort of cardiac involvement. It may even cause a STEMI or an arrhythmia and make that situation a little bit worse. So if you're at the point where you're using epinephrine, don't be afraid to, but just weigh the pros and cons, and then make sure you get a 12 lead afterwards and make sure there's no untoward side effects. Just like I said, every patient with shortness of breath should get a 12 lead, regardless of whether or not you use epi. Or if you go back to our top 5 list of causes of shortness of breath, the heart is one of those things. Getting a 12 lead is an easy way to rule out the heart's involvement here. So we look at some cases. You start with a 60-year-old man who's short of breath, has a history of COPD, and it's been getting worse for the last 2 or 3 days. Says his home nebs aren't helping. And you go in and he looks like this. He's tripoding 2 or 3 word sentences. He's clearly in respiratory distress. And you note that he's hypoxic at 72. What are you going to be your first steps? Well, should be pretty straightforward. I'd immediately set up the CPAP. You can kind of make your CPAP judgment from the door, right? Remember, we're going to base this on work of breathing. And you can base it on capnography too, but I usually base it on work of breathing, which you can see from far away. You're going to set up your capnography. You're going to get a Duoneb going, that 2-pronged attack against his inflammation, and give him some of that PO Dex before you put that mask on his face. In the meantime, while you're getting your CPAP set up, you can have somebody working on an IV to give him magnesium and start working on a 12 lead. By the time all that is done, he should have had several minutes now with your therapies, and you can consider whether or not you want to give him epinephrine. Now, one of the most important points here, I think, is that all these medications and interventions are the exact same thing I would do in the hospital, and you're able to do this right in the patient's home. So there's no rush to get him off of that scene and get him in the ambulance, because you're doing the same thing that the hospital is going to do for him. So take your time, get him stabilized, do all the things, get him a little more comfortable, and then you can move him. Case number 2 would be a 10-year-old asthmatic, minimally interactive, looks tired, hypoxic, increased work of breathing. You see retractions. Now, how are we going to manage this kid? Because these are both obstructive processes, but there's some subtle differences here. For him, obviously, we don't have pediatric CPAP, so we'll start with the Duoneb, give him the Dex. Those are the same things that are going to decrease that inflammation and open his airways. Can work on an IV, think about MAG. A kid is going to be less prone to cardiac side effects than an adult would. So in these, you can consider epinephrine early, especially since you don't have the added benefit of CPAP here. I would be more prone to considering epinephrine early because there will probably be less side effects from it. And that is all I have. So if you have questions or want to talk about this, please contact your 7-8 or feel free to reach out to me and I'll be happy to talk a little bit more. Thank you for your time.